Hello, I'm Bonnie Geyer from UW Extension Family Living Programs, and I'm pleased to welcome you to this webcast on perinatal mood disorders. I know many of you are home visitors who are working with new parents. You may be wondering how to tell if a mom is experiencing postpartum depression, what to do to determine if there is a problem, and probably most importantly, what to do if treatment is difficult or impossible to access. We have someone with us today who is uniquely qualified to help us think through these topics. Jennifer Perfetti is a licensed counselor who has worked for several years at the UW Parent-Infant Early Childhood Clinic that's part of the UW-Madison Medical School. She also has a private practice providing individual and couples therapy during pregnancy and postpartum. And what you probably won't be able to tell from looking at her is that Jen is quite pregnant, so that makes her even more qualified to talk about this topic. We plan to have question breaks at various periods along during the webcast, and to ask a question, all you need to do is press the Ask button that you will find at the top right-hand corner above the PowerPoint slides. We'll compile the questions, and then when Jen is ready for questions, I'll ask them for you. I'd also like to ask you to click your Ask button right now to register your attendance at this webcast. I'd like to let you know that this webcast will be archived for 6 months at the same site that you used to get on live, and also that if you experience technical difficulties during the webcast, you can call 1-800-442-4614. And with that, I'm going to turn it over to Jen.
Good morning and welcome everybody. I'm going to assume you're all out there. This is amazing technology to me. I'm going to be here with you talking today about perinatal mood disorders, a full range of postpartum depression, anxiety disorders, a range of things that women are often prone to experiencing in the postpartum period. And I'll be going back talking from pregnancy all the way through early parenting as we discuss these issues. As Bonnie said, and thank you for the introduction, I have worked at the UW at their postpartum depression treatment program for some time, and in private practice I've also been lucky enough to facilitate new moms groups for about a year and a half, so I've heard hundreds of new moms coming through talking about their experience with infants and as new mothers. I also currently facilitate a postpartum depression support group at a parenting resource center here in Madison, and I do couples workshops as well. So I really try to look at the wrap around the whole family during this period, and how we can be of help in getting families off to the right start. So today, I'd like to start with just reviewing the symptoms of postpartum depression and anxiety disorders that can come up during this period. And for a lot of you, this may be familiar and may be a review, but I think it's a good place to start on the same page. I'm also going to talk a bit about screening and how you could implement a brief screening tool at your sites. And hopefully this may be something that some of you are doing already. And if so, I'd love to hear about your experiences and any roadblocks that you've hit that I can help to troubleshoot. We will also talk about finding resources and what are the treatment and referral options for postpartum depression, what are the different effective treatments. And then I'm going to focus quite a bit of time on the options for women who aren't receiving treatment formally, because I'm hearing that that's an area of need. And so to think about two categories, women with mild to moderate depression, and what are some self-help options to help them through a difficult spot if there aren't resources available or if they're not open to receiving formal treatment. And then for women with moderate to severe depression, thinking about how to mobilize formal treatment, because this generally isn't a group that it's wise to go without some sort of treatment. So thinking about how to help talk through that, think about options, and get them into treatment if possible. And then I'm also going to talk about couples relationships because I feel like that is so key often in a woman's well-being and functioning is how things are in her couple relationship. Yeah. Okay. I'll try to talk louder as well. Thanks for the feedback. So helping couples is really an important piece here, to look at the whole family and both the women's functioning, but also the relationship and how that whole family is developing as new parents. So first we'll talk about signs, symptoms, and risk factors of a range of perinatal mood disorders. Probably familiar to a lot of you is the postpartum blues, which is really to be expected. So 50 to 80% of new moms experience the postpartum blues. Probably towards the 80% is more common. Generally, it begins pretty quickly after the birth, usually about within the first 3 days. And an interesting fact that I was told is by the end of pregnancy, a woman has the estrogen hormone equivalent of 500 birth control pills a day. So that's where she's at the end of pregnancy. She has this baby and it just drops instantly. So within that first 3 days, there's some major hormone stabilizing going on. And so that's really what sort of brings on that postpartum blues, is just her hormone levels evening out. And it can be scary for women who weren't expecting it. So I think it's a nice thing if you're working with somebody during pregnancy to just let them know that this is going to happen, that it's common, not to be concerned, and that it's something that most women experience, and that it should even out within the first 2 weeks. So generally, we're not looking at postpartum depression until after 2 weeks, because it's hard to say, okay, is this just the hormone and the blues evening out for this woman still? But generally, symptoms come and go. There's just a lot of mood fluctuation, tearfulness out of the blue, feeling irritable, just sort of a quick fluctuating between different feeling states. And it comes and goes. So it's not, where depression, as we'll talk about, is more pervasive and more stable and hard to pull out of. This is like you'll be feeling in love and excited with your baby one moment, and then you'll just burst into tears the next, and you sort of feel all over the place. Postpartum psychosis is very rare, as you probably know. There's prevalence is about 0.1% of the population, but it's a very severe and serious thing that needs to be addressed immediately. It should be seen as a medical emergency. Generally, it occurs rapidly within the first week following birth. And the symptoms are true to psychosis in general. So you're going to have some form of removal from reality. So you're going to have command hallucinations or visual hallucinations or auditory hallucinations or some sort of break from reality, often severe agitation, racing thoughts, severe insomnia. So not just, I'm having trouble falling asleep, but I'm not sleeping all night. And some paranoia, irrationality. And if you're seeing elements of that in a mom, it's very important to get connected, call 911, or get her into the emergency room, because this is the situation where women or their babies actually are at risk or at danger of being harmed. The foremost situation. So postpartum depression, which is sort of right between on the continuum. So I like to see this as a continuum with the blues on one end and psychosis on the other end, and postpartum depression falls along the middle, is quite prevalent. 8 to 15% of mothers experience postpartum depression after a birth. And when I say new mothers, I don't necessarily mean first-time mothers, just with the new birth. Up to twice as many women in poverty, just due to the additional stressors that they face. There really is some debate still in the literature and the research as to what role hormones play in postpartum depression. They're finding less and less that that's the case. I think often people are preconceived to think it's hormone-based, and it's being seen much more as life change and stress-based. And so a lot of different factors, which I'll talk about, can really put a woman at risk for postpartum depression. But then the encouraging thing is, there are some biological aspects for some women, but when it's life-based, that means there's a lot of opportunities to get in and help her feel better quickly. It can begin any time in that first year postpartum. So most commonly, you're going to see women experiencing signs of postpartum depression within the first 3 months. They may or may not recognize them that early, and it can happen anytime in the first year. And for some women, different stages are more or less difficult. So some women really enjoy the newborn stage and have a harder time when their baby begins crawling and becomes more autonomous or is getting around the house and getting into things. So really that whole year, it's going to last at least 2 weeks. So again, if this is not the on and off bad day that every mom has. So we're going to be needing to talk about how to piece out what is just the hard parts of being a new mom and what is postpartum depression. And this 2 week sort of idea is a good distinction, because there are many times where new moms will just have a horrendous day. They'll be falling apart, feeling tearful, but then the next day things feel better, the next couple days. This is more pervasive and more long-lasting than that. Anxiety can be a very central component, and I'm going to continue talking about anxiety. But it can be hard to recognize for women, because I think we, over time, may get some better terminology as we're piecing out what women experience in the postpartum period. But right now, it's all lumped together. And so you think depression, you're not thinking of those anxiety components. So a lot of women won't recognize, okay, maybe I am experiencing a postpartum depression here. So it's important to know that anxiety can be very central and often more disturbing and upsetting for the woman and more prominent than any kind of depressive symptoms. And without treatment, it's found that 30 to 70% of women experience postpartum depression for a year or longer. So this is something that really does tend to linger and be difficult to cope with without some sort of help or active change. So looking at the DSM criteria for postpartum depression. So if we're going to look at the formal clinical criteria, you would be looking for 5 or more of the following symptoms listed here. So depressed mood, often accompanied by anxiety. Diminished interest or pleasure in activities, which is often humorous for moms because they have reduced ability to do any kind of activity when they have a newborn. So I try to keep that framework of simple things. So you have a conversation with a friend, or you have a good meal, or a hot shower. Do those things feel pleasurable, or are you just feeling so blah or numb that nothing feels good? Appetite disturbance. Generally, what we see more is the inability to eat. So not having any appetite, having to be reminded to eat, partners having to push them to eat, just feeling either so busy and caught up in the baby that they're forgetting about their own needs and not feeling hungry, or just really feeling sort of yucky, not wanting to eat and really having to push that. Sleep disturbance, again, is of course common early postpartum. Your baby's not sleeping. So what we ask is, when your baby's sleeping, are you able to sleep? So your baby's sound asleep. Are you up with racing thoughts and you can't utilize that time and get a restful sleep? So it's not, or, when you're up for those nighttime feedings, is it then very hard to fall back asleep? Those kinds of sleep disturbances, how you can piece it out postpartum specifically. Physical agitation or psychomotor slowing, and often for women during this period, it's the slowing and that just feeling of no energy. I can't get up off the couch. I really can't function in my life right now. Fatigue, decreased energy, feelings of worthlessness or inappropriate guilt, and quite often this guilt is around parenting and not feeling like a good parent and not feeling like they're giving their baby what they need. But often, in addition to sort of the normal amount of that you'd expect, they're then racking themselves over the coals for every past mistake they've ever made or every, minor thing with their baby that a lot of women would be able to sort of put into perspective more readily. Decreased concentration or inability to make decisions is a big one that women just feel paralyzed by, what am I going to cook today? Or how am I going to dress my baby? Or how am I going to get myself to Target to pick up the things that I need? And those little decisions just feel immobilizing, and they will avoid them or just sort of push through them. But they feel like a huge deal, much more than they would at other times when they're not experiencing depression. And sometimes recurrent thoughts of death or suicidal ideation. Often women will become feeling so hopeless or so just in this hole that they don't see a way out, and they'll start to have thoughts of, my baby would be better off without me, or I can't handle this baby, and they start to have thoughts of hurting their child. And we would talk much more about assessing that and doing safety assessments, but often it's not uncommon to have some of these thoughts in a passive way. So the baby, I'm so tired, I just don't want to do this anymore, or I want a way out, or I want some escape. And these escape fantasies can be really common and aren't necessarily a heightened sign of risk. So it's important to be able to talk about them openly and normalize them and let mom feel safe discussing them with you without being concerned that, it's going to raise the troops right away. And again, we'll talk about piecing out when there really is some increased risk. So again, looking at these symptoms, most of them have overlap with being a new parent and having a newborn: the sleep disturbance, the exhaustion, the guilt that new moms often go through, even the cheerfulness and depressed mood. So you're really looking at the combination of things, that there are 5 or more things happening at once, and that they're lasting most of the day, nearly every day, for 2 weeks. So it's, again, not just the on and off bad day. So that's the formal diagnosis. What do we hear from moms? What we hear from moms, I just listed some terms here that I think are helpful because it's the language that moms use as they're talking about feeling depressed. And the most consistent one we hear is overwhelmed. So just saying, I'm overwhelmed, I can't do everything, I can't keep up on things. So just that exhausted, overwhelmed kind of feeling is the most prominent. Anxious or worried, particularly about the baby. So having a lot of fears about the baby's health or safety, or whether they're parenting well. Feeling anxious about leaving the house, feeling anxious about being alone in the house, just things that wouldn't be typical for them, particularly, if it's a big change. Before, I was really independent and I could be alone at home just fine, and now I'm terrified when my husband goes to work and I'm alone with the baby. That kind of stuff we hear a lot. Feeling constantly tired, not having energy to be doing the kind of parenting they need to be doing during this period. Being awake with thoughts running through their head, crying often. I hear a lot of, just tearfulness, and with moms in person or reporting being more tearful than usual. Not enjoying being a mother, feeling disconnected from their baby, feeling like that early bonding isn't happening like they expect. And that can really intensify things, because that guilt component then gets triggered, and they're feeling guilty about not being connected to their baby. And then the more guilty and depressed they feel, the less they're connecting with their baby, and it can become a really circular pattern. So that's a wonderful area of intervention, and I'll talk about that as well, is to really facilitate that mother-infant relationship and help them feel more connected. Feeling like a bad or inadequate mother, and anger or irritability towards others, and that's particularly partners. You get a lot of irritability towards partners, and just nothing he does is right, and then you end up with increased couple conflict, which also can exacerbate the depression. So those are the things I feel like I hear most commonly from moms directly. So risk factors. It's important to be aware of risk factors, because particularly to help with early intervention. So to know during pregnancy, if possible, if a woman's at risk, and to start thinking with her about supports. So any symptoms of depression or anxiety during pregnancy are really important to note and to start taking seriously and have conversations with mom about this, because generally that's not going to improve after the baby's born. Pregnancy is a hard time, but in the grand scheme of things, it's not as hard as having a newborn. So you're going to have more stress and more difficulty when that baby comes than you are during pregnancy. So if already the woman's struggling, you really want to look at that carefully. Having a history of depression or mood disorders herself, or anxiety disorders, or a family history, it's just important to note it doesn't mean that she automatically will have postpartum depression with this baby, but it does mean there's an elevated risk, and it can be good to think about, what kind of supports, what kind of postpartum planning can we do to make sure that this period goes smoothly for you. Perceived negative birth experiences, and I say perceived because that's very individual for every woman. She may have, birth that others would say, it was a safe birth, you have a healthy baby, you should be fine, where for her it somehow didn't meet her expectations or was disappointing. That can be very, very significant in getting a woman started during the postpartum period. And there are also situations where birth experiences can be scary or traumatic, and there's some sort of emergency sense that, there's an emergency C-section or some sort of emergency intervention that can really just start a woman off feeling vulnerable and afraid, and in that state of things just didn't flow along smoothly. And sometimes parenting's hard enough during that early period, so any extra bumps can really just throw things off in the wrong direction. Quality of social support and marital satisfaction is a significant risk factor to look for. So is this woman isolated in her life? Does she have a network of friends, particularly women friends? Particularly other women friends with babies is great during this period, just as far as people to rely on. But does she have family around? Does she have a partner who is invested and involved in her life and in helping to raise the baby? All of these things, really help carry a woman through the postpartum period. So it's important to assess her network of social support. Are there any physical health problems in the mother or the baby? Again, it's just those added stressors that really sort of push women over the edge. So if there's even a difficult physical recovery after the birth, something that's more difficult than typical, or the baby having any kind of medical concerns that bring increased fear for the baby's safety, can get a woman started on the wrong footing and just, again, more vulnerable during that postpartum period. And any significant loss or life stress in the last year can really just raise a lot of grief as that baby's born and impact the woman's mood. So we'll talk a bit about the anxiety component as well. So as I mentioned, intense anxiety is often a prominent feature of postpartum depression. And it can be confusing for women and providers if they're only looking for depressive symptoms. I've had a lot of situations where women have come to me and said, oh, my doctor said it's not postpartum depression, because they're just seeing the anxiety piece. So it's really critical to know that it can look like anxiety or be anxiety and still be considered postpartum depression and need to be treated as such. Generally, the type of anxiety we see tend to be panic attacks, or fears or obsessions around the baby and the baby's safety, and having ruminating thoughts. Breastfeeding often tends to be a big source of anxiety if they feel like they're not producing enough milk, or they're worried that their baby's not growing well. They'll tend to really fixate on breastfeeding and get anxious to the point of obsessive there, which of course then inhibits letdown and makes breastfeeding harder. So again, that circular effect. And sleep is the other thing. Really, sort of, a lot of new moms tend to get a little obsessive about naps and measure their whole day, whether the baby naps well or not, and get sort of wrapped up in exactly how many minutes did the baby nap, and what's that mean, and how do I get my baby to sleep better? And sometimes taking some of the pressure off of sleep can be an important thing too. But generally, this anxiety is reported as more distressing from women than depressive symptoms, and it also can spiral into depression. So women might start with a high level of anxiety And then, it's difficult to maintain that state, even physiologically. And so you see the woman then sort of drop into a depression and more of a withdrawn, hopeless kind of state. Symptoms of anxiety, the worry component has to be there. So you've got some sort of excessive worry and difficulty controlling that worry. And then on top of that, you've got a sense of restlessness and being keyed up and on edge, fatigue, difficulty concentrating or mind going blank. And again, you see some overlap with the postpartum depression symptoms here. Irritability, muscle tension, so you'll feel that physical tension or have shoulder or back aches, and sleep disturbance, difficulty sleeping with ruminating thoughts. And if you look, there's a handout called the Postpartum Mood Disorders Guide that I had given everyone, and that just lays out really nicely some of the disorders that I'm not going to get into in depth, but it lets you know the full range of things that women tend to experience during the postpartum period. So the blues, PPD, postpartum psychosis, but then panic disorder, postpartum obsessive compulsive disorder can be common, post-traumatic stress disorder can be common. And really, I think a good way to look at it is just that the postpartum period is a stressful time that then triggers these things. So it's not necessarily that having a baby, that something physiologically causes these things to happen for the first time, but that the combination of your change in role and lifestyle and the stresses of having an infant, the sleep deprivation, the exhaustion, can trigger some mental health issues. And these are the ones that are most commonly seen in women during the postpartum period. So right now, all of these things are often grouped under the term postpartum depression, and I think it can be very helpful as a provider and as somebody working with women to be able to piece them out a little more carefully and say, okay, I think what you're experiencing is post-traumatic stress disorder, or is panic disorder, you're having these panic attacks, or is more of a depression with true depressive symptoms. And it just makes a difference in how you talk about it with the woman, what kind of treatments and supports she's looking for, and what kind of help she needs. Okay, so before I go on to talk about parenting and infant development, are there any questions on recognition?
There haven't been any. You must have
Okay.
really well.
Okay, all right. And feel free to type in questions as we go if anything comes up. So we'll talk now about the impact of postpartum depression on parenting and infant development. And the reason I think this is important is partly to recognize, okay, why is this issue significant in general? Why do we need to be getting in there and helping new moms and supporting new families if they're struggling with postpartum depression? But also, to a degree, you can use some of this information to help moms with buy-in, too. When you're trying to encourage them to seek treatment, it's an important balance because moms have a tendency already to be feeling guilty during this period and be feeling, whether they're acknowledging it or not, to be feeling like they're not a good mom or they're not giving their baby what they need. And so to talk too much about the impact of depression on parenting can be really stigmatizing and really heap on that guilt. So I would recommend taking precaution in doing that, but sometimes talking about, in a gentle way, what their baby needs from them or how important they are to their baby can be very validating as well, and can also give moms that boost and that motivation to get help for themselves. So generally the symptoms of depression can lead to impaired ability to be involved in the child's physical care and play and to meet a child's normal needs of depression. So the mom, just due to that sort of despair and hopelessness and lack of energy and being pulled in, sort of internal with her own difficulties, sometimes to muster up the energy to shake that little smiley face rattle over and over, or get down on the floor and play with your baby, or smile and, mirror some of the positive affect that babies need to imitate to develop socially. That can be really hard to do when you're feeling depressed. So, and as I'll talk about, we see some impact on babies of that inability. Often, as I mentioned, women will have difficulty bonding with the baby, and that'll really increase their feelings of guilt or inadequacy as a mom. Often there's anxiety about doing psychological harm or physical harm to their baby, and that sometimes can cause women to withdraw. So they're worried about their impact on the baby, even if it's, I'm depressed, and my baby's going to see me depressed, so I'm going to pull away so my baby doesn't have to see me depressed. So then, the result is a break in the connection there, which again intensifies things between mom and baby. Studies have found that depressed moms show more matching of negative behavior states in their infant and less matching of positive behavior states. So when their baby's crying or fussing, they tend to respond to that more readily. When their baby's happy or cooing or just sort of a neutral state, that's often when they check out and they're not responding and encouraging that. So you end up with some early negative reinforcement, essentially, where the baby's realizing, okay, I get more of a response from mom when I fuss and cry, and so increasingly the baby's fussing and crying, and that of course can set up some early patterns. And depressed moms often hold a more negative view of their interactions with their infants and show more anger in those interactions as well than non-depressed moms. And so often the infant will display the same action or state or interaction, and the mom will respond to it more negatively, or she'll just view it as more of a problem. So where another mom might sort of, okay, he's having a bad day today, or, be able to sort of run past it more easily or not. This mom is, oh, he's so hard to deal with, and he's so fussy, and just see it as characteristics of the child versus a changing and fluctuating state in the child. Bidirectional effects in mother-infant interactions, and again, this gets back to that social mirroring. So, as I'm sure you all know, infants are amazing at imitating adults' expressions soon after birth. And so that's how they learn socially. They imitate your facial expressions. They open their eyes wide, you open your eyes wide, and you make funny smiley faces, and then they start to learn to do it back. They can stick their tongue out in response, within 2 days after birth. And so the concern here is when mom's got a flat affect and a depressed affect, what is that baby then mirroring and responding to? And often we see that babies start to look flat themselves. So they start to mirror a depressed affect. And there's some question that hasn't been answered yet in the research, but can that actually introduce a depressed state in the infant? Is that developmentally, if you're constantly displaying a flat affect, does that affect your hardwiring as you're growing and lead to future depression? It's one theory of possibility. We know, there's sort of anecdotal things that they'll say, if you smile more, you'll feel happier throughout your day. And that tends to be true. And so if a baby is looking depressed, mirroring this depressed affect, are they feeling sadder throughout their day? Another impact of this is if the infant is flat and unresponsive, he's not drawing mom in or being as rewarding to mom. So those babies that smile and coo and pull you in tend to make people want to interact more. And some babies do this naturally. We've seen even babies with depressed moms who will then reach out to other people to try to pull in for interactions. But if a baby doesn't have that natural tendency and starts to look flat and isn't responding to mom, that can really, again, impair her sense of being a good mom or her sense that her baby likes her. And so again, it can cause mom to pull away because she's feeling like my baby doesn't respond to me, my baby doesn't like me. And often you'll see moms turning their babies out when they're holding them, and they'll say, oh, the baby, likes to look at other people. And often it's initiated by this feeling of rejection, that their baby's not responding to them. And so they start to turn their baby out, which then further hampers any opportunity for increased mother-infant connection. So it can have sort of a long-term domino effect there. In the research, we found that infants of depressed mothers can show less interest and more anger and sadness and more fussiness than infants of non-depressed mothers. So again, you see it in their regulation state, in their affect state, that you already from infancy you're seeing some differences with mothers who are depressed and mothers who aren't depressed. Roseanne Clark over at the UW has found clinically that mothers who are depressed often have infants who are sober, sad, or flat affect, have regulation difficulties, sleep or emotional regulation, poorer attention, poorer eye contact, fewer vocalizations, so language development often tends to be a little slower, and more limited exploration of the environment. So that secure base isn't quite as established and they're not as ready to go out and explore. And then we see the impact all the way up through early childhood and school-age kids. Just a couple examples from the research. Intrusive and overstimulating care, which often you see in mothers who have experienced postpartum depression. There can just be a tendency to miss their baby's cues and be really intrusive with the baby and rough handling, that kind of thing. And that has been associated later in kindergarten with symptoms of attention deficit and hyperactivity disorder. So you see the rise in some of these childhood disorders, and you need to wonder about what was the very early infancy looking like, and what kind of parenting was this child receiving, and what are the links with later disorders, and this tends to be one of them in the research. And the other, so when you have moms who have postpartum depression, often you'll see either that intrusive overstimulating care or the withdrawn unresponsive care, and that often can predict externalizing behavior in the child. So they're doing a lot more to try to get a response. So then you've got a child who begins to be aggressive or hostile or really try to escalate things in order to get a response from those around them. Again, I think it's really important, though, to recognize that the fact that a woman has postpartum depression does not automatically tell you how she's parenting. And, that's a lot of the things I just went over. There are many mother-baby pairs who have beautiful relationships, who have very responsive relationships, and are able to do that despite the depression. So I don't want to, write that off as a given, but it's just important to be aware of those risks and to help support in those areas with the mother-infant relationship. Some factors that can help mitigate the risk to infants: the course and timing of the depression, so the chronicity. Moms who are chronically depressed over a long period of time, particularly, they aren't getting treatment, the depression is recurring throughout that child's childhood, you're going to see a lot stronger impact than a mom who has some depression early on, gets treatment, gains coping mechanisms, and then is able to really help monitor her depression. That baby's going to have a better prognosis long term, obviously. The mother's degree of sensitivity in parent-child interaction. So a lot of moms are really aware that, okay, even though I'm not feeling like it, I know my baby needs me to sing to him, or my baby needs me to play with her. And they can really sort of push themselves through it and be sensitive and attuned with their baby. The mom's personality, comorbid psychopathology, and relationship history. Relationship history, particularly if she's had strong and nurturing relationships in her past, it's a lot easier to be able to replicate that with her own baby. If she comes from a history of abuse or unresponsive parenting, you don't have the template or the example of how do I be a good parent? How do I interact in a loving and nurturing way with my baby? So you're trying to create that from scratch, and on top of your own depression or anxiety. So if a mom has had that experience of warm and nurturing parenting, it can be a really protective factor. And anxiety, we've actually found, can be protective to a degree. Often moms who are more anxious tend to be more responsive to their baby because they have a heightened awareness of their baby's needs and have some worry about meeting those needs. So the positive side of that is sometimes that they are more attentive and more responsive. The availability of fathers and other caregivers can be very important during this period to help offset some of the things that mom might not be able to offer as she's working on healing herself, bringing in dad or bringing in grandparents or aunts and uncles or neighbors or people who can give baby some of that, bright affect and developmental interaction and stimulation that is needed. Length of maternity leave has been found in the research to be correlated with risk as far as long-term effects on infants. So often moms, I think the cutoff was 6 weeks of maternity leave. Mom who had less than 6 weeks or felt forced to return to work before they were ready tended to struggle more, and their babies tended to struggle more during that period than moms who were able to return to work electively or had, over six weeks of maternity leave. So it can be an area where if there's any flexibility to help encourage families to think of some creative solutions to either go back to work more gradually or, just try to think about their maternity leave and how to balance that time. And characteristics of the child. Babies are born with a lot of different temperaments. So if there are babies that are pretty easygoing, that can mitigate risk, obviously make things easier for mom. Fussy or colicky babies can really intensify any kind of depression or mental health issues for mom. And gender has been found to be correlated in the research that I think particularly American women, it seems that the mothers of boys, it's often might be good to explore what that means to them if their child is a boy or a girl, because mothers of boys in our country tend to have higher rates of postpartum depression. And often, it's unlike what you see around the world, but I think it can be wrapped up sometimes in poor relationship histories or experiences as a child. And so sometimes working through it or talking about some of that can be very helpful. So screening. We'll talk about... Oh, okay. Before I move on to screening, I'll pause.
We have a couple of questions, and one of them was to get a link to the handout. So I'm going to give people my assistant's email address to email for them. And then there's a question for Jen, too. If you don't have the handouts, would you please email elaine.barrett@uwex.edu. And Barrett is spelled Barrett. So I hope that helps as far as handouts. She should be able to email them to you. The question, Jen, was, can these things happen when people adopt?
Yes. Yes, they definitely can happen. And again, I think that goes back to the fact that we're realizing more and more that it's not necessarily a biological-based disorder or a hormone-based disorder. We talk about it as biopsychosocial. So it really brings in many components of someone's life, and adoption, particularly if you're adopting a newborn and going through that same exact experience of sleeplessness and fatigue and the intense need of a newborn, we see very much the same patterns of postpartum depression in adoptive parents. And also it's important to toss in there that fathers are at risk of postpartum mental health issues as well. They also experience stress and triggers and can have increased rates of depression or anxiety postpartum. So talk a bit about screening, and I really advocate for routine screening at site. So this is something to consider strongly if you're able to work it into your home visiting programs. We've found that or the research has found that up to 50% of women with postpartum depression are missed if routine screening isn't used. So if you're just relying on the woman reporting her depression or being able to see some signs of depression, they found that that is not reliable at all, that 50% of women fall through the cracks, don't get help, and are missed by their primary care physicians in this study. So why are so many women missed? I think stigma is a huge part of that it is very, very hard for a woman to acknowledge postpartum depression still. I think there's a lot more openness to it. There's more talk in our culture about postpartum depression. There's more and more, celebrities or people coming forth having experienced postpartum depression, but there's still this sense of it means that I'm a bad mom, or it means that I'm not as good as that mom sitting next to me in mom's group who seems to be doing just fine, which is always interesting to me because I think women put on a really good front for that hour in mom's group, and so they all seem like they're on top of things, everything's going smoothly, and I've had a lot of women come in, for example, at the postpartum depression study at the UW, and they'd say, why can't I do as well as all these other women in mom's group? And then we'll see 10 other women from the same mom's group coming through our program. So there's just this sort of hiding that still happens. And often once one woman breaks the ice and starts talking about her difficulties or her feelings of depression, then other people will pop up and start saying, oh yeah, I've experienced that too, or start telling their stories. But it can really be hard to break through that. Generally, there's a tendency to minimize symptoms or attribute them to the average demands of being a new mom. And understandably, as I spoke to, it's very hard to piece out sometimes what is just being a new mom and what is postpartum depression. So that can be difficult. And it's an area where a screening tool can be useful in just making that concrete. And anxiety being more prominent often makes it difficult to recognize. Media attention, I think it's always interesting to look at how postpartum depression is portrayed in the media because it can do some good and some damage. I think well-publicized or highly publicized tragedies can increase response from a provider perspective. So I think that's where this can be beneficial is providers are more alert to asking about postpartum depression or being on top of the symptoms and signs and treatment options, which can lead to an increase in early identification and treatment. But on the flip side, for moms, I think it can be very stigmatizing when these cases often aren't portrayed very sensitively. And often everything is lumped together as postpartum depression where, like in the example of Andrea Yates, there was psychosis going on. And that was very specific and very central to what happened in her case. And so when you just talk about that as postpartum depression, then women start to feel like if I acknowledge that I have postpartum depression, people are going to think I am like Andrea Yates or I'm going to kill my baby. And so it just can really lead to increased stigma and decreased likelihood of acknowledging the depression. So I think the more, we can be accurate in labeling what is happening in these cases as much as possible and not overhype and blend everything into postpartum depression, it will serve women better. And it can be very helpful to have women who are admired in our culture come forth. And Brooke Shields was a wonderful example of that. She wrote a book called Down Came the Rain, which is a fabulous book. I would very much recommend it to moms because it can be, particularly if they aren't in a place where they have a network of other moms experiencing postpartum depression, to read somebody's portrayal of this and realize, wow, I'm not the only one going through this. I'm not the only one feeling these things. Even somebody like Brooke Shields can feel what I'm feeling. That can be validating and can reduce that sense of isolation and shame. So what are the opportunities for screening in your home visiting programs? If you are working with women during pregnancy, I would absolutely say to start screening during pregnancy. So either that first visit to start looking at risk factors, or any time during the third trimester. And I have the screener here for you, so I'm talking vaguely about it. I'll talk more specifically. But so to give the woman the screening tool during pregnancy then allows you to do some planning for the postpartum period. So if she's scoring high already, you've got some time, which is really nice, to be looking for resources in the community, to be thinking about who can bring her meals after the baby's born, who can come help do some laundry after the baby's born, those kinds of things, and bring in those supports. Postpartum, 6 weeks and 3 months tend to be 2 target points if you were looking at implementing something on a routine, structured basis. But really, it could be any visit during the first year. It's just helpful to use this tool repeatedly. And it is not repetitive to use it over and over at various time points, because a woman's experience can change so rapidly. What she's feeling at 6 weeks might be very different from what she's feeling at 5 months. And so to check in again is a good thing, to use this over and over and help her to gauge where she's at. And again, it just makes it concrete and sometimes safer for a woman to just do this paper and pencil instrument, can actually make it less embarrassing or less stigmatizing. It's a little familiar to just fill out this form, and then it gives you some sort of measure of how she's functioning. So informal, unstructured screening is one, it's sort of a baseline possibility. You can use clinical impressions. Is mother acting depressed? How well is she functioning? Sort of get a view into your view of her affect and life. But again, moms can really sort of put a good veneer over how they're doing. And so it's not a reliable way of predicting, and it's generally effective only when the depression is so severe that it's that apparent. The Edinboro Postnatal Depression Scale is the one, that screening instrument that I would advocate use of, partially because it's so simple and easy to implement. It's only 10 items. It's very, very quick. So it's not, an increased burden as you are going on a visit and you already have, this list of things that you're hoping to get through. This is something that's very easy to slip into your routine and use quickly, but it is very effective. It's an instrument that has been studied. It's been translated in many, many languages, maybe 30 languages, and it's been studied around the world. And it's effective multiculturally in many different cultures around the world. It's effective at different time points throughout pregnancy and postpartum. And so it just has very good reliability in picking up postpartum depression. And it's free to reproduce, which is another nice thing. You can Xerox it freely as long as you've got the authors cited at the bottom. And the easiest place to access it would be at the WAPC website that I've got listed here. That's the Wisconsin Association for Perinatal Care, and they've got it posted. On their site, I also have given out copies in the handouts in English, and on the website, it's listed in both English and Spanish. And I believe they have a Hmong screener as well on their site. So you've got examples, and I won't go through this just to save time for other things, but it's 10 items. One of the nice things about the Edinboro is it covers depression and anxiety. So some of the screening tools don't even touch the anxiety component, and that is very important. One question to point out that often bugs people: things have been getting on top of me in the top right corner. I think that's where it's, yeah. A lot of people, so this is a British tool. So things have been getting on top of me is sort of funny wording for a lot of Americans, but I actually like that item when it comes to feeling overwhelmed. I feel like it really does capture. So what they're trying to capture there is feeling overwhelmed. And often, if you put it in terms of that, if a mom's having trouble with that item, or what do they mean by that item, ask her about feeling overwhelmed. Or one mom said, I always feel like I'm going 1 step forward and 2 steps back. And so it's that sense that's getting picked up on there. And then it's really important to discuss the screening results either way, whether a woman scores high or low. And I should mention that the cutoff here, you can use a cutoff score of anywhere from 10 to 12. So 10 would be a very conservative cutoff if you want to overcatch people. So that would be the lowest number where women might be exhibiting signs of depression. 12 you could use as well if you don't want to overcatch too much. It's better to overcatch than undercatch and miss people. But so you're picking a score from 10 to 12 and using that consistently within your agency, depending on how you want to use the tool. But often, if a woman fills this out, you want to talk with her afterwards so she knows, okay, I filled this out and how did I actually score? And so you're either going to talk with her about her score being elevated and indicating potential depression and then talking about resources and what kind of support she needs. Or if it isn't elevated and she is scoring beneath a 10, still talking about how she's feeling. And she may be struggling in other ways. She's not scoring high on the Edinboro, but that doesn't mean she doesn't still need some support. So making sure that you're having that discussion, regardless of her score. Okay, and I'll pause for questions then.
We do have 2 questions. One of them is, we do a home visit, one time only in most cases, at 4 to 6 weeks postpartum. Is this too early if no further follow-up will occur?
Okay.
So is it too early to do the screening?
Am I back on? Yeah. No, I would say it's definitely not too early. And I would recommend if you're there once to use the tool, because that's still a great way to catch women. 4 to 6 weeks is great because you are past the blues, ending at about 2 weeks. And so it would just be important that you have some ability to follow up if she does score high. And it might just be following up on the spot with some resources that you bring along with you. You might choose to have a community resource list that you have with you at every visit. So if she scores high, you can say, here's some people to contact. But no, I would definitely advocate for going ahead and using the screening tool.
Okay, and then there's a second question. If a client is on antidepressant medication, do we still screen using the EPDS?
Yes, that's a great question. And the reason it's so important is often women are on antidepressant medication and it's not helping enough. So either they're not on a therapeutic dose or the medication isn't effective. And if they're taking medication and still scoring high, that's really significant. And they should be back in contact with their prescribing physician to help adjust that medication. So I wouldn't rule out that just because she's on medication that it's actually effective. A lot of women, that's not the case. Any other questions? No? Okay. All right. So formal treatment options. Okay. So there are several treatment options for postpartum depression, being medication, psychotherapy, and there are different forms of psychotherapy, individual psychotherapy, group psychotherapy, and mother-infant psychotherapy. And as I've talked about with the mother-infant and couples relationship, I would really advocate for a relationship-based approach as you're seeking a therapist or some sort of formal treatment. The first step in any treatment modality would be meeting with some sort of mental health professional who has experience in this area and helping to piece out, is it depression, is it anxiety, are there safety issues here? Often a woman's only contact is with her primary care physician, who may or may not have any level of expertise or experience in mental health. And so if there's a way to link with a mental health provider, that can be really important. I've seen many situations where women are just handed a medication with no follow-up and no opportunity to talk further and get further support. So helping to make that link and not just relying on a physician can be very important. Medication during breastfeeding is something to just be aware in helping a woman piece out this decision. That there are, and I'll just pull all these up for you to look at, but it should just be a risk-benefit analysis as you're thinking about what are the risks of taking medication versus what are the risks of unmedicated depression and the impact that has on parenting. And there's not a lot of research out there. There's some studies that are being done increasingly that are showing that medication during breastfeeding can be safe, but we do know that all medications enter breast milk. So it is just a decision that should be taken carefully and cautiously, but But again, recognizing that untreated depression impacts that parenting relationship as well. Oops. Okay, so getting to the toolbox and what you can do to help support moms and babies during the postpartum period. So first, as we're talking, and all of you are here watching this program because you have a heightened sensitivity to the importance of postpartum depression. So keeping that in mind as you're interacting all the way from pregnancy, just being alert to risks of depression or signs of depression already puts you so far ahead. So you're at a prime position to observe mom over time during multiple visits. You're in her home, which often means she's more comfortable, ready to be more honest and open, and you're also getting to see some cues as to how that family is functioning. It can be important to start a dialogue about risk and symptoms early on and really portray it as a partnership, that the two of you are going to look at this together, and that it's not this sense of her being monitored from the outside, or that can increase defensiveness, but if it's really, I want to help get you off to the best start, and so let's look at this together and see how we can get supports if needed and that kind of thing. And assessing risk early in pregnancy, which we've talked about, and beginning prevention planning if there does seem to be elevated risks or if you're seeing signs of depression or anxiety, to then begin planning and putting supports in place. Oh, thanks. So again, of course, reminding you that you're not responsible for her treatment. So this is just an opportunity to help be aware of the need and help make those linkages, which often are hard to do, and we'll talk about that. Using your relationship with mom as a basis to explore and problem solve can be very helpful. So that's where, if you have an ongoing relationship, to use that trust and that sense that you just care about her and her family's well-being as a starting point is going to help her be a lot less defensive and feel less stigmatized. And then you can talk directly about some of the barriers that might make her less open to seeking help. So there may be stigma around postpartum depression that you can talk through. She may see depression as a sign of weakness. Talk through some of that. There may be cultural expectations of mothers or of therapy. So, a good mom looks like such and such, and therapy means, you're going to go in and someone's going to mess with your head, whatever kinds of things, ideas that they have. Or just that, sometimes people don't think of therapy in the context of relationships, so they feel like they'd have to go in and that first session spill all of this personal information, which can feel very intrusive. And so recognizing that therapy is a relationship that builds, and they don't need to tell the therapist everything from the first, they can get to know that person and begin to form a trust, and gradually talk with them about things that are important. It can, just help to debunk some of that. There can be a lot of fear around entering the system, fear of losing their children, fear of letting somebody else in to their personal life. So talking through those issues. And then barriers like cost or transportation or childcare can take a lot of brainstorming, but often there are possible solutions or people in their life who are willing to help, like transportation, for example. They may have a friend or a neighbor who's willing to drive them somewhere if they'd just be open to reaching out for that help. So really helping to problem solve and think outside the box on some of these issues is important. So moms with mild to moderate depression, I'm going to talk about self-help options and things that can be really beneficial. If they're not getting formal treatment for whatever reason, what can they do, and what can you help guide them with? So often women are so invested in taking care of others that they're not taking care of themselves. So a great starting point is just promoting self-care and giving her permission and recognize the importance of self-care, and that as she's better taken care of, she will be better able to take care of her baby or her family. And often just getting that permission can be really important for women. And to recognize that self-care is important in preventing postpartum depression and anxiety, and also important in coping with it. So some increased self-care can actually prevent problems down the road, and that can be a nice thing for women it can help motivate them around that. Having more realistic expectations, slowing down the pace. I love this photo of the woman multitasking. She's on the phone, she's on the computer, she's holding her baby. We see a lot of that now and it's often, there's other kids in the picture too. And so women are just trying to do so much at the same time. And they aren't often very flexible about letting go of their expectations of housekeeping or socializing or meals that they're preparing or they feel like they have to do such and such and such on their schedule, when really a lot of that can give. If you really look at it carefully, some of the things that they feel like they have to do and it absolutely can't slide, if you start to talk about what would be the worst that would happen if you didn't do A, B, or C, there's really not a disastrous consequence. And you really can, for a period of time, let some things go without everything falling apart and give yourself a break and see this as a period of respite. Postpartum. And it's also important to put that in the framework of bonding and allowing time, unstructured, unbusy time for bonding with your baby. And if you put in that time early, it's really going to help your relationship with your baby to develop and help that long term. Helping moms think about nurturing themselves and taking time out for themselves, treating their emotional needs with respect, giving themselves little special treats throughout the day. And they may be very small. It might be, I'm going to eat a piece of chocolate and, after, a meal, or I'm going to actually linger for 10 minutes in the shower versus rushing in 30 seconds. And, just thinking of things that you enjoy that you can actually see as treats for yourself throughout the day. Connecting with others can be an important way to do that. So to reach out and call a friend or ask a friend to stop by or take your baby and go out for coffee. But deliberately nurturing yourself and seeing that as a way to then nurture your baby and your family. Spirituality for a lot of women can be an important source of self-help. Both the spiritual community being a good support, but also just using prayer as a calming or reflection time. I had one mom who, for her, spirituality was very important, and so she decided to start getting up 15 minutes earlier in the morning than her kids, and she would just have 15 quiet minutes to read and reflect and pray, and that really helped her to get her day off on a centered way. And that can be anything. It might be, that mom likes to meditate in the morning, or that it's just deep breathing and having some quiet time to think before the house gets into chaos. But really having some calming, centering time built into every single day can help keep that anxiety level low and help get your day off to a good start. Taking breaks, and often for moms, when they have a break when baby's sleeping or something like that, then they see that as time that they can work around the house. So then they're trying to do laundry or cook or do something that they consider productive. And so I actually try to really encourage moms to not do something that they feel like they need to get done during that break, to actually do something that they like to do or something that's restful and replenishing to them. And trying to schedule, if possible, brief breaks throughout the day. Sleep is probably one of the most critical factors, and it's something that, again, can be brainstormed, how to get a mom more sleep. There was a study that was done with graduate students where for a month, all they did was deprive them of restful sleep. So they would sleep. Every time they hit a restful delta wave sleep, they would wake them up. And that at the end of the month, a majority of these healthy students had clinical and biochemical signs of depression. And this is what most parents experience when they have newborns. The baby is waking up on their time clock, not on your time clock. So you're continually getting prolonged, unrestful, disruptive sleep. And that has a major impact. And so helping a mom strategize around sleep is incredibly important. And sometimes it can be important to see sleep as a treatment on its own and to help her think of it as a treatment. That this is not just a luxury. This is actually something you're doing to help heal and get better and recover from your depression. And so helping to think through, can, a partner give a baby a bottle, even if it's pumped breast milk during the nights? Can, sometimes we'll even strategize for mom to go away for a night just to get a booster of good solid sleep, and it's amazing the kind of impact that can have. Along with napping during the day if possible, really thinking about a 24-hour sleep schedule, because that's how newborns sleep. They're on a 24-hour schedule of being, sleeping periodically and being awake periodically. They're not quite getting that night-day concept yet. So if mom can replicate that and help boost her sleep, that can be very helpful too. And exercise, which is a touchy subject because it's really hard to get exercise with a newborn baby. And often women are feeling so badly about their body postpartum that it can be hard to get motivated because you're, exhausted and don't feel physically fit. But if there is a way to bring in some exercise, meaning just walking with your baby, nothing hardcore but just walking around the neighborhood with your baby or trying to do more physical activity. We just know there's a big link between exercise and depression. And if there's a way to build that in, that can be very helpful, but it's important to have that conversation sensitively, because to say get more exercise when she can't even get a shower is pretty hard to expect sometimes. Nutrition can be very important, to take a look at having healthy nutrition. And often, moms are just sort of snacking at whatever's on hand during the day because it's so hard to even find space or time to make a healthy meal. So to make sure you're helping suggest quick, easy food choices to have around the house that she can pick up on instead of chips or things that are going to deplete her body. And not thinking about it, again, from a weight perspective, but just an energy and depletion perspective. That the healthier foods she has, the more energy she's going to feel. And again, not a lot of moms will really overuse caffeine or something like that to sustain them through the day, sugar or caffeine, and then end up crashing. So looking at nutrition together. And omega-3 fatty acids. I'm going to spend a little time talking about that directly because there have been some amazing placebo-controlled clinical trials that have shown omega-3 fatty acids, specifically the DHA, to reduce depression. So particularly for a woman who is not wanting to take medication, or even as a good first step, it can be a nice thing to try supplementing with fish oil and see how she responds. And for some women, that really will help sort of give them that boost and reduce the depression. In the research, it's shown that cultures with greater seafood consumption do have lower rates of depression, even when they control for other factors, other cultural factors. And American women generally reduce or completely eliminate fish during pregnancy and breastfeeding due to concern about mercury. So you can see how, this would be an area that we would be depleted and need some supplementation. And the nice thing about the fish oil caplets is you can find sources that are third-party tested for PCBs and mercury. So you can make sure, it's very important to make sure of that, and that you're getting a source that does not contain mercury. But in fish oil, as long as somebody's not vegetarian, it's the most readily accepted form to our system to increase the DHA, and I've got the recommended amount there as well, 2 to 4 caplets, and what levels you'd be looking for a therapeutic amount. That would be helpful. And then thinking about how you can help mom activate her circle of support. So moms groups can be really wonderful, even if they're not related specifically to postpartum depression, just to connect with other new moms, hear some of these things that are common to being a new mom and realize you're not alone, and reduce that social isolation that's often a big part of things. Bringing in dads, significant others, family members, and assessing the support conflict ratio. I've got a little note about here because often, particularly mom's mom, that can be a difficult relationship to navigate, and sometimes there's more conflict than is worth it to try to bring her in as support. But sometimes if you can help work through that, it actually can be very healing to experience that support, maybe for the first time, in a way that's genuine and needed. But really thinking creatively about who are people in this woman's life who can be a support network to her right now, and who we can help pull in. And social isolation is really critical during this period. We're not meant to be alone in a house with a baby and nobody else. Historically, women have parented in extended family systems or in larger community systems. And so just thinking about the fact that that's not a natural way that we have parented historically. And so it's an unreasonable expectation for mom to be alone all day with a baby and feel like she should be happy with that. And that often can help decrease some of that stigma to recognize that. And then some informal supports for postpartum depression. There's a phone support line in Wisconsin. There's local support groups that can be found through PSI. There's some web-based support. A lot more women are making use of chat rooms and web-based support. And I think that can be really good to a degree. It's hard to monitor, and it's hard to know what kind of information they're getting on the web. So there's some concern, but these are two that I've heard particularly good things, and moms can really create a community through the internet that can feel as real as a community in their neighborhood. And recognizing that you play an important role just in supportive communication as a home visitor, and that is not necessarily something they're getting in other areas of their life. So somebody who is willing to listen as an active intervention and hear what they're saying without stigma, without judgment, just being able to tell her story and realize that somebody can hear and accept them and not think they're a horrible mom and not be looking down on them for having depression. That on its own can be very healing. And so recognizing that's a big part of what you're offering this mom, whether or not she's in any kind of formal treatment, just being able to talk through some of her feelings is critical. And not getting too caught up in the problem solving right away. I have a note there that understanding must precede action. And I think a lot of times as helpers, we want to solve problems quickly. And so there can be a impulse to jump in with, okay, here's these resources and here's these ideas, but to really take some time and just listen to what she's feeling and experiencing first. And then, when she's ready, okay, can we think through some ideas together to bring on additional support? And then supporting the mother-infant relationship. And the reason that I feel this is so important is because a lot of women are not feeling competent as a parent when they're experiencing postpartum depression, and they're feeling that increased guilt. So the more they can feel competent as a parent, the more that reduces their depression. So helping them to learn their baby's cues, and that might mean suggesting using part of your visit just to be together with the baby and having special time one-on-one. And then you can model and guide mom in developmentally appropriate play, in soothing activities, in singing or making daily tasks playful, diaper changes, feedings, that sort of thing. Helping her to do some of that face-to-face mirroring, to think about bright affect and smiling. Even if she doesn't feel like it, if she can start portraying more of that, she's going to get that response from her baby. And then the more her baby smiles back at her, it's going to feel genuine. She will then get filled up with, wow, my baby's smiling at me, and you get pulled in, and my baby likes me. And then pretty soon you do feel like smiling at your baby, and it becomes much more genuine. When the baby is fussy, help wonder with the mom about what the baby is needing, and help her. Sometimes there can just be a sense of helplessness about, I don't know what my baby needs. I can't do anything to make this baby happy. And often as an outside provider, you can really help think through some of the baby's needs. And the more effective that mom is feeling in her parenting, the better off both of them will be. And then supporting and reinforcing any positive affects, really watching for her to do something right, and then helping to reinforce that and build upon that. Speaking for the baby can be a nice way to highlight cues. So helping to really amplify the baby's smiles or what the baby might be saying through their interactions or facial expressions or cues, and helping to make that clearer for mom, because often moms, particularly with postpartum depression, tend to miss those cues and not be as responsive. Modeling gentle handling, and helping mom to not be intrusive in the way I had talked about earlier, and helping with some non-judgmental developmental guidance of what's realistic to expect at different ages. And dispelling myths about spoiling young babies, helping mom feel comfortable in responding to and holding her baby, and knowing that those things are really critical to the baby's development and to their relationship. So moms with moderate to severe depression, safety needs to be an important part of that conversation. So it can be, again, important to think about stigma here and reassure mom that you want her to feel safe and secure. You want her to feel comfortable being alone with her baby and to know that she's safe and her baby's safe, and that's why you're talking about these things with her. And being very matter of fact about it. And again, can help decrease the intensity around this issue, that it's just something that a lot of women have thoughts about or experience concerns about. And so let's talk about this together. I have a couple examples of openers that you can use. But normalizing that it's difficult to talk about it, but at the same time not backing off and being afraid of that conversation can just help open the door to an area where a woman's got so much shame potentially that she is not going to readily acknowledge thoughts of harm to herself or her baby. And it's pretty critical to be asking those questions. And giving emergency resource information. So even if you're getting any inkling that there might be some of these thoughts or feelings of hopelessness, just to give her a number, which I'll give you in a minute. Even if it's not needed now, if things are feeling worse for you, I just want to make sure you've got this, because it's hard in the moment to find resources. So as you're doing a safety assessment, thinking about harm to the infant as well, you want to ask about the nature of the thoughts, and just for your own gauge of risk. Moms typically do experience some anxious thoughts, and if they're vague, it's not quite as concerning. So fear of something happening to the baby. I'm afraid that I'm just going to be so tired or overwhelmed that I'm going to lash out at the baby. It can always help to prompt them, that it's a good thing to be able to put your baby down in the crib and go take 5 minutes and do some deep breathing and sort of pull yourself together, that is a really useful and important tool. So knowing when they're getting flooded and when they're hitting that point, and to be able to put their baby down and walk away in a safe place. But generally for moms, it's very ego dystonic, meaning they find these thoughts horrendous and they have no intention of acting on them. They hate that they have these thoughts. They tend to be repetitive because they're so anxious about having them that then they have them more. But you're really looking for mom saying, but I would never do that. I love my baby, trying to reassure you that they love their baby, that these thoughts really don't fit for them. The more concerning, and you still want to take it seriously in either way and help mom feel safe, partly for her own sake, to help decrease that anxiety. But the more concerning situation is when there's some psychotic thought process, and so there's some command hallucinations or a true sense that that baby would be better off dead than with her as a parent, that kind of stuff. Often there's a religious component to that, something related to God or being better off with God. If you're hearing those kinds of elements, I would certainly be calling in some outside help or calling 911 or taking that quite seriously. And then looking at mom's history. Has she been impulsive or violent in the past? Does she have previous diagnoses, such as bipolar disorder or psychosis, that might make you a little more concerned about her risk? And helping her recognize what are her triggers for when she has these kinds of feelings. What are her coping strategies? Who does she call? Who knows about this? Making sure she's not the only one and you're not the only one who knows she's having these thoughts. That if she has a partner or a family member involved, that she does talk openly with them so that other people are helping to monitor and support her in feeling safer. And it can help as you're doing safety planning to contract verbally or in writing to say, okay, here's the things you do if you start feeling unsafe. You call me, you call your partner, you call, whatever list of supports and steps. And to make that very concrete, because in the moment when somebody's feeling desperate, it's really hard to think through those steps. So making sure that you're thinking through those steps together and beforehand is important. Again, involving another person. Removal of means. If she has a very concrete thought of, I'm going to use a knife, make sure there aren't knives available and that they're getting locked up. And seeing this as, I want you to feel safe in your home. That's always a great way to help keep this as a partnership and not help her feel victimized that somebody's coming in from the outside and monitoring her, but that she too is feeling anxious about these thoughts, and it really helps feel safer if she knows that there's not this ready ability to act on them. Identifying triggers, planning support and respite, and doing that regularly. So not just when mom's feeling desperate and then she's at that breaking point and then support comes in, but actually using support, somebody coming in for a couple hours a week regularly as a preventative measure versus in response to an already elevated state. Then hopefully you don't get to that elevated state because you've got this built-in support and a little breathing space in the week. And knowing your emergency options, so 911 and ER being obviously the most universal. There's a talk line, 1-800-SUICIDE, and that's a national hotline, and they will connect you with local suicide hotlines. And here in Wisconsin, I've got a website for that lists several local. So if you go to this website here, I forget how many regions, but for various regions, they list what are the local community mental health centers or suicide hotlines in each area. So if you don't find one in your area, then you can use the national one. So as you're trying to really encourage these moms with moderate to severe depression to get formal treatment, it can be important to remind her of some of these things, that to be the best mom she can be or to support and nurture her family, she needs to be supported and nurtured, and really put it in that context. And reminding her that she isn't crazy or weak or to blame, or some of the thoughts she might carry around this. And that sometimes just getting outside input or ideas or support is helpful, and trying to decrease the stigma around therapy and what therapy is, and that it's just a relationship with another person who really is there to help support you through this period. And then recognizing that in addition to a woman's hesitance or fear about treatment, the symptoms of depression make it hard to follow up on things like therapy. So to help with this process and help facilitate this process as much as possible, and to call and make the referral with her permission, or get her permission to have the provider contact her. So sometimes handing a mom a phone number and expecting her to follow up just isn't realistic, and it's not going to happen, and she's going to fall through the cracks. So whatever you can do to facilitate that initial connection, even if it means taking her to her first appointment and driving her, because often until she's got that relationship with someone and she sees a face and she sees, okay, this person is somebody I can feel comfortable with and trust, she needs a lot of hand-holding. Along the way, I've had moms who've, been pushed by 4 different people before they finally get in to see somebody. And it's also important, especially if you're in an area that has more resources, to help her be a good consumer and meet a couple different therapists if possible, and find somebody who she does feel comfortable with and who she does have a good fit with. And know that, the relationship is one of the most important elements of change. And so it's okay, if she feels like somebody was dismissive or didn't get her or was not empathic, to try someone else. Give her permission not to just have to work with this person who she didn't connect with, but to actually find somebody who she does connect with. So again, sort of a 3-tiered approach. If there's urgent, what are the signs of an urgent, immediate danger? What are the signs of acute danger and something that you want to take seriously but isn't a go immediately to the emergency room situation? And then the standard outpatient therapy. So psychotherapy and or medication. And I always tend to advocate for psychotherapy as a first order of treatment, just because of the potential side effects or long-term impact of medication. If you can use psychotherapy and actually learn coping skills versus medication, which treats the symptoms, and sometimes, very importantly, I'm not at all discounting the need for medication in many cases, but you're often then not addressing the underlying issues or learning those coping skills that can help a woman long term. So psychotherapy can be a really important component here. And then locating some outpatient therapy resources. A wonderful thing to know about is the Wisconsin Maternal Child Health Hotline. They're particularly good with Medicaid resources. And they recently, the Wisconsin Association for Perinatal Care, in the past couple years, tried to do a statewide push on finding out who does offer resources around postpartum depression, who are the experts around the states, and they compiled that information through the Maternal Child Health Hotline. So you can call them or access them by web to get some wonderful resources for various mother-infant issues. And if you're in the Dane County area, the UW Postpartum Depression Treatment Program can be helpful in finding local treatment options. Mm-hmm.
We have a question, and it might actually fit in this next section very well. It's, have there been any studies on postpartum depression in new fathers? I don't know if you want to answer it now or if there's a logical time.
I'll answer it just because, unfortunately, it's a short answer. There aren't any studies that I know of. So I know, I'm trying to think if there's any formal studies, but generally the research tends to be focused on women. And I'm trying to think where, but I know that I have heard that there is elevated risk, as I mentioned. But I can't link that to a specific study as I'm thinking off the top of my head. I think some of it is clinically that therapists have also seen heightened numbers of fathers having need in this area. I know I certainly have in my practice, particularly when I'm working with couples. That's when you get the dads in, is they're not often seeking treatment themselves because they feel this need to be a provider or be sort of bolstering their spouse, who's the one seen as, the new mom who should have greater needs. So often dads are dismissing their own needs or trying to not address them. When you get couples in together, that's when you start hearing, okay, dad's really struggling during this time too. But I don't know of any formal studies. So couples, just to shift over to this area, it's a very, very critical, and it's important to think outside of just marriage as we're talking about couples and the impact on both the woman's well-being, the infant's well-being, and just going through this transition to parenthood together. 33% of births in our country are to unmarried women, but 85 to 90% of those babies are born to committed couples. So those unmarried women are not necessarily unpartnered. And it's important not to dismiss the importance of that partner, and to really try to find ways to draw that partner in, both as a parent and in that relationship. Only a quarter of our households these days consist of married man and woman and children. So most families are not looking like that typical model. So again, it's just important not to disregard dad and focus too much on mom, and to really find ways to draw him in as you're working with the family, because this is a very risky period for couples. It's a very stressful period, and 25% of married parents divorce within the first 5 years after their first child's birth, and 50% of unmarried couples separate in that first 5 years. So when we're talking about intervention and a critical point, this really is, that bringing in a child for the first time particularly is a critical period in the evolution of couples relationships. Up to 67%, 2/3 of couples experience a decline in relationship satisfaction after their first child is born. And that blew me away when I first heard that 2/3 of couples are less happy in their relationship after that baby's born. And so just recognizing what a period of stress this is, and that's normal, and helping to normalize that for couples. And generally, mothers experience the decline first. Often their role shifts much more drastically than dads, and they're the ones who are suddenly finding themselves in the home, to a greater degree than they ever were before, doing a lot of the homemaking tasks and feeling like their roles are much more off balance with their partner than they ever were before. And then their dissatisfaction then often leads to dads experiencing it more later in the first year and then throughout the second year postpartum, often as a result of mom being very frustrated and dissatisfied in the relationship, and then dad not feeling like he can do anything right and starting to pull away as well. Becoming a parent changes things in very important ways, and so it can just be important to validate that, as I said, for couples, and to think very carefully about the fact that they're becoming parents together, regardless of what their relationship looks like. Even if they are not choosing to live together and parent together in that sense, parenting still connects a couple for life most of the time through their child, and often trying to help couples rise to that task for the sake of their child can be really important long term. And it requires, a couple to establish mutual goals, to be able to communicate and agree on things that they may historically have trouble communicating on. And it's not instinctive, so couples really need a lot of help during this period. There's a Bringing Baby Home workshop that's created from the research of John Gottman, who's been doing research with couples since the 1970s. It's something that I'm certified to offer in Madison, and I think there are a couple other providers in the state. But it's in a randomized clinical trial, this workshop has been shown to help couples maintain their relationship satisfaction, to reduce hostility and increase affection in couples, to promote parent-baby interaction, and to promote quality father involvement and father satisfaction. And that's a pretty key component of the workshop. And it's also been shown to reduce postpartum mood difficulties for both parents. So it's got some nice research-based clinical backing to it. And I think one of the things that's nice about the workshop, and I'm bringing in some material that I'll share with you, is working, as I hopefully have been talking to throughout this, is working on different levels. So looking at parent-infant interactions, looking at couples' relationship, looking at individual well-being, and weaving all of those together in a really nice way. So what are tools that you can use as home visitors to support couples as they're becoming parents? A big piece is just normalizing the transition to parenthood, helping them to recognize that across the board, couples experience this decline in satisfaction, that it is a profound shift in identity and values and goals, and that relationships change when a baby comes, and that this change can be temporary. Things can get back some degree to, what it was before baby, but it will never be fully back to exactly what your relationship looked like before baby. But knowing that it's universal, that conflict increases, that sex decreases, that conversation and communication becomes more difficult after a baby enters the relationship, and that helps couples know it's not just something wrong with us, that this is something people go through, and it's normal. It doesn't mean that we can't try to improve some of these things, but it doesn't mean there's something inherently wrong with our relationship. During the transition to parenthood, often fathers tend to withdraw, and this has a lot of early domino impact. Right away, often there's a society of women that sort of bustles in when a baby's born, and so mom's mom is there, her friends are there, her sister's there, and this society of women can really push out dad without meaning to. It's not, generally not a malicious thing, but there can be, some accepted ridiculing of how incompetent dad is, and often mom doesn't know what she's doing anyway, but it just becomes, sort of this funny thing to talk about how little dad knows when he's with the baby. Either way, it can just be a lot of, I'll do that, and, sort of pushing dad to the margin. And this is a really important time in that early bonding period for the family to, mom, dad, and baby, to bond and connect, the three of them, and really have that early bonding as a framework for later. So to just make sure to keep dad in that circle from the beginning. Often dads will get really activated in their provider role and will start spending more time at work and decrease, potentially, because of this feeling marginalized, but they'll start to decrease their sense of being important at home. Okay, baby needs mom, so I'm going to work more so that I can bring in extra money to support the family. And that can really be a mistake that can lead to more and more distance between dad and baby and between dad and mom. And often, dads who are in unhappy relationships, their babies tend to withdraw. And we see the babies withdraw from dad, not from mom. So if that relationship isn't functioning well, or there's stress between the couple, we see babies look less to dad for support and reinforcement and cues and interactions, and they start to withdraw and pull away from dad and prefer mom, which again makes dad feel even more marginalized and less important in that family life. There are physical and psychological changes that are normal. So again, as we're talking about with couples about the transition to parenthood, sleep deprivation, the impact of that, decrease in sex drive for women, that is normal, and to help both partners learn about that and realize that is normal. And mom may be less emotionally available to partner. How does that feel for dad? Helping them recognize and talk through some of that. As you're trying to help couples stay in touch with each other and stay connected to each other and their baby during this period, helping them increase their awareness of each other's world can be very important, because often their worlds are so separate. Even, when in situations where both parents worked, during even a short period of time, there's generally some sort of leave where mom usually is the one who's at home and doing all of this baby care and sort of feeling isolated in her bubble with baby, and dad's off at work, and they're in such different worlds that it can be difficult to understand what each is doing through the day. So helping them to stay connected, be talking about even the mundane elements of their day. And the importance of affection and appreciation and utilizing that, making sure to up the appreciation, because it's a time that both partners tend to feel devalued and underappreciated. So prompting them to increase that area. And then helping both of them to understand baby's communication, as I spoke to earlier, can really help each of them feel more competent as a parent and stay more engaged with baby. Helping partners coordinate their play is another role that you can give input on. So generally partners don't even think sometimes to play together with their babies. We do so much multitasking and so much tag team parenting that one parent will be with the baby and the other one's trying to get things done. So recognizing the importance of spending some time playing together with your baby, doing fun things like bath time with your baby, that's a good thing just to encourage from the start, and then helping couples to do that in a mutual way that's not competing for attention or having one parent be primary all of the time when they're playing together. Thinking about the importance of touch, and I want to be able to save time for questions at the end, so I'm just going to go through this quickly, but we are a very low-touch culture. There's a couple interesting studies that looked at, for example, observing 1-hour conversations in coffee shops in Puerto Rico. People would touch 180 times, in Paris 110 times, and in Florida 2 times. So we do not touch in our culture, and that really can translate to the home. And children who are raised without that affectionate, warm touch, caressing, holding, generally tend to be more distressed, more insecure, and clingy. So helping parents to know that, again, that idea of you're not going to spoil a baby, that responding to an infant's needs and holding a baby and keeping a baby physically close to you is actually going to help create a secure and confident child who is comfortable in their surroundings, and that it does not work the opposite and make them insecure and clingy. And sleep can be an extension of that. For some families, co-sleeping is a really good solution, often for preserving mom's sleep postpartum. When we're going back to the postpartum depression piece, if you can breastfeed your baby and both gradually fall asleep versus having to get up and walk over to another room and be that much more awake, moms will often find that they get a much more restful night's sleep with their baby close by. But it can just be interesting to know that 66% of all babies in the world sleep with their parents, and 2/3 of 136 societies. So it's not just, a couple less industrialized societies that tend to use this pattern until baby is weaned. And we don't outgrow this need for touch. So there was a study that found that 15 minutes of partner massage each day helped to reduce symptoms of depression. And this can be a very difficult issue because often, because of the decreased sex drive and interest in sex that women experience postpartum, there can be a hesitance to touch at all. So either mom doesn't want to touch or be physically affectionate with dad because she's worried that it will lead to sex, or dad's trying to be respectful and not be intrusive, and so he's not wanting to touch her because he feels that she might think he's trying to initiate sex. And so then you end up with a couple who's not just touching each other's arm or hugging or doing things that help communicate physical affection, and that can create more and more distance. And we know there are quite a few effects of distressed relationships on children. And I've listed some of them here and have spoke to some of them a bit already, but we tend to see impact even all the way through school, and that children tend to do less well at school, have more mental health and behavioral problems, even be less physically healthy when there is a lot of relationship conflict at home. John Gottman did an interesting study where he gave couples of 3- and 4-year-old children a marital satisfaction questionnaire, and he also took a urine sample to look at the cortisol stress hormone in their child. And he could see just as clearly from the child's cortisol sample the relationship distress as he could see from the marital satisfaction questionnaire. So these kids are carrying physically the impact of this conflict and stress in the home. So it's one of the reasons that it's so important to do some couples intervention whenever possible. And help couples think about avoiding fighting in front of the children and strategize how to do that. So setting aside a problem-solving time when they talk with their partner. Don't discuss issues that might upset you in front of the kids. Couples generally fight about the same things over and over, and they know what those things are. So helping them not bring them up when they're in front of the kids on its own can decrease that level of conflict. And it can be hard to sit on that, but when you know what's going to be a hot issue, don't bring it up. And don't discuss problems during meal times, particularly. There's some links with eating disorders there. And if an argument does happen and the children witness it, it's very important to do some reparative work and especially have a physical hug and kiss in front of the child. That's the language that kids understand. And so for them to see you hug and kiss and make up at the end of an argument really helps to put them at ease. I've been weaving in the importance of fathers, but a big part of that is through play. Dads have a very different style of play that's more physical, encourages more exploration, and they've found in studies that has wonderful benefits for children. And as I hope we all know, play is not idle. Play is kids' work, and it's very important in their development. And Dad's particular style of play predicts later better self-control abilities, better social competence and emotional IQ, better social acceptance, even verbal and academic performance, and increased empathy as adults. So having that warm, nurturing fathering is really a critical element for kids. There was a beautiful study that was out of Stanford of 300 families when kids were 5 years old. And they followed up 26 years later with these 5-year-olds. And they found that the best predictor out of all the factors they looked at of their level of adult empathy was dad's involvement in their child rearing. And then again at 41 years of age, they looked at their social relationships as adults in work, family, and marriage, and found that increased warmth from dad as a baby predicted better social relationships. So there really is a key relationship that should be nurtured and brought to the forefront as much as possible. And women, of course, that's sort of a given, that women are happier when their relationships when they're feeling supported in the parenting role by their partner. And when their partner is taking an active role in parenting, all the pressure's not on them, and they tend to do better as well. So just to wrap up and leave a few minutes for questions, just knowing that you are in a critical role to help families, and you often are mom's most frequent contact postpartum, and have a wonderful opportunity there. Knowing the impact of depression and the importance of that awareness, implementing screening and early identification in your programs, helping to mobilize treatment, increase self-care for families, and that your intervention really can support the entire family, and you're all doing good work with that. So.
We do have 2 questions. One of them is there any liability if the mom won't follow up on the resources they're given and she hurts herself or the baby?
I would always document. I would document your recommendations to her and document her response, because I think that helps to protect you from liability. So to write down that you did express concern, to write down that you did attempt to offer resources. You can't control for whether or not she accepts those resources, but you can record that you offered them.
Good. And then the last question is about the Bringing Baby Home workshop. When is it recommended to take this workshop?
I'd say any time from pregnancy through 2 years postpartum, so up through toddlerhood, it's equally applicable. And often parents, tend to have subsequent children, and so if they're using it with their first child, even after birth, it benefits them later as well. I find that couples often have more time to access a workshop like this during pregnancy, but it often has more impact after their baby's born, because they start to actually feel and recognize some of these issues and can't write it off as easily of, oh, we'll be the exception. So it really hits home after the baby's there.
Well, that's our last question. And Jen, I really want to thank you for spending your time here with us today. I thought it was very valuable. I hope that the people that were sitting at their computers benefited. And we really appreciate everybody joining us today. Don't forget that it is available, will be available for 6 months as an archived webcast. So if you have colleagues that haven't participated today, you can help them find it. Thank you.
Thank you very much.